Yelena, I have patients come in, especially young patients who have just been diagnosed with gastric cancer, and they're worried about their children. And they say, is there something, I'm now have gastric cancer, do I have to worry about my children having gastric cancer? What are there any hereditary gastric cancer syndromes that are around, and are they prevalent or not?
That's a great question. And we do see increasing in incidence of gastric cancer in young adults, young males. And in fact, based on this data, and the fact that the returning veterans and young, servicemen actually are developing gastric cancer. There's a high-risk population. The Department of Defense is now funding some of this research to try to look into both, hereditary and exposure, predispositions. To highlight the most relevant gastric cancer sort of genetic predispositions, the first comes to mind that is the best described is probably the hereditary diffuse gastric cancer syndrome. In those patients, the prevalence and the penetrance of the CDH1 gene mutation is high, but that's a rare syndrome, and it's a relatively clear picture if someone presents at a young age in their early 30s, so that may not be your typical patient who's asking you, will my children, be affected? Those type of patients could be actually in there, the tumors could be related to Lynch syndrome or MSI, gastric cancer. The microsatellite and stable tumors are characterized by large mutation burden. However, interestingly, in gastric cancer, most MSI tumors are somatic MSI, so they're not associated with Lynch syndrome. That being said, if you see a lot of gastric cancer, you will see Lynch-associated gastric cancer, and that should always be on your mind when screening the Lynch patients. So when sending them for skin check, urologic check, colonoscopy, you should also consider stomach cancer. And lastly, one of the very interesting and therapeutically potentially relevant syndromes is this homologous repair deficiency, or the BRCA-like gastric cancers. And being from New York and having a lot of patients of Ashkenazi Jewish descent, I see quite a few patients with BRCA-associated gastric cancer. And those patients, they have a real therapeutic potential here for platinum, stratifications, but also for exploration of PARP inhibitors. So the field has evolved, and we are certainly interested in the somatic side of the tumor, but the germline data is just as important and needs to be considered.
I mean, you bring up a lot of important points, and we talk so much now about molecular profiling of patients with cancer as well. And so I guess, what are your recommendations? So a community oncologist sees a patient who's, let's put them in the middle, somewhere like 40 years old. Middle low.
40 is young.
Yeah. And thank you for saying that, by the way.
Well, we're in the same.
And it comes in with gastric cancer, so a little bit on the younger side. What would be, if you're recommending to a community oncologist, what do you get baseline no matter what? And then what's your wish list?
I'm glad you asked that question. So the wish list is now reality. With pembrolizumab approval in MSI high patients across solid tumors, and with HER2 amplification being also a level 1 recommendation in terms of it should be routinely done. The culture in gastric cancer has been to do sort of a stepwise approach to testing. First you test, all the regular H&E and IHC to make sure it's adenocarcinoma. Then you start with HER2. Then you do some other biomarkers, maybe MMR. EBV is an important biomarker, and then you get to something else and you run out of tissue. So in 2017, we really should plan on doing a multiplex assay, and generally these next generation sequencing assays, which should be considered a standard, in these patients. At this point, you can assess HER2, you can assess MSI in a prospective and standardized manner. And although MSI gastric cancer is rare, it is a real entity. and in metastatic patients could have a significant impact in their outcome for treatment.
And Dr. Shitara, in Japan, do you also check this at baseline too?
Yes, for metastatic disease, we should check HER2 status because we have a trastuzumab as a HER2 targeting agent. And at this time, checkpoint inhibitor have not yet been approved for gastric cancer, but in our institution, we already start to profile this metastatic patient based on MSI, bioimmunohistochemistry, and EB virus status. And also we are doing a profiling study using NGS, which may identify the optimal, some druggable gene alteration.
Yeah.
So,
sounds very consistent. What about Yelena and Manish, same thing?
I mean, certainly for us, testing for HER2 is standard. I think increasingly similarly in our institution, we will test for mismatch repair, but with immunohistochemistry. But I'm not quite sure, certainly in the UK, there is actually funding to test all gastric cancer. It is routine to test all the colorectal cancer, but it's not routine to test all the gastric cancer. But actually, while we're at it, there's one extra point about when you're saying what you talk to your community oncologist. In fact, there is also an educational role that we have to teach our community gastroenterologists, who often do the diagnostic biopsies, is to make sure that they take enough of them. Right. And because we quite recently did an audit in our own practice, looking at patients being referred in from our community hospital gastroenterologists, how many they're taking, and actually apart from how many, the number of biopsies they're taking, which day of the week that they take the biopsies also matters, because it then depends on how long they sit in the paraffin and processing. So Thursday is not a very good day apparently.
Manish, is that the same for you?
Yeah, no, I agree with what was said. I think that multiplex sequencing is a very good point, especially with the limited tissue, related to the difficulty of diagnoses. I mean, I think that part of it is getting adequate tissue. Part of it is that it is a difficult disease to diagnose at times as well. You see an ulcer, you may not be prepared or get the right biopsies and things like that. But I think that is a part of it. The other part is that with regard to diffuse gastric cancer, we know that those tumors have some characteristics. They're unlikely to be HER2 positive and things like that. And I just want to touch upon what Yelena said earlier about the management of high-risk patients. So for Lynch syndrome, the screening for other malignancies is very important, but for diffuse gastric cancer, patients who carry a germline mutation should get a prophylactic gastrectomy above the age of 20. And that's something, the risk of getting stomach cancer is about 1% per year. And so the recommendations, the guidelines are to, in fact, get a prophylactic gastrectomy at some point in your 20s to reduce the risk of getting stomach cancer in the future. So it's just one thing I wanted to make sure community oncologists hear as well.